All right, we're going to go ahead and start our next lecture on amputees or amputations. So just like any chapter in the textbook, I do want you to look at the very beginning and of all the definitions, but an amputation is just simply the removal of a limb, part of the limb, or any portion of the body. And we'll keep on going. So, first things we'll talk about for amputation has a lot to do with their energy, like I said, especially for any kind of activities that they do throughout the day, as well as ambulation. So, when it comes to ambulation and energy, those that have an amputee, it just depends on how much of the limb that was amputated, especially for the lower extremity, will definitely make it more impactful the higher up, let's say a transfemoral amputation, they're going to require a lot more energy if they have a prosthetic to move the limb when it comes to walking speed. Versus if it's just like a Sims, like at the ankle, then usually they have like a normal or a larger stride length and a more efficient walking speed. So, the most efficient average walking speed for normal individuals is approximately 3 miles per hour, and about walking at 5 to 6 miles per hour requires more energy than jogging. So this is just saying in general, but with added weight, like such as like a prosthetic, is going to increase the energy expenditure. But the head being the most efficient place to carry extra weight, obviously, and the feet the least. Therefore, this is why amputees have an increased energy demand. And it will make a difference too if it's like on soft or uneven ground surfaces. This will increase the energy demands up to 40%. Stairs, which all these percentages is just going to based upon the individual. That's why, and depending on the level of the amputation, but it can be anywhere from 20 to 140% increase to go up ascending stairs, and 20 to 80% of energy demands to go to descend stairs. With if they were partial weight bearing with crutches, that's going to require a 33% increase in energy demands, and non-weight bearing is 78%. So a trained individual is going to definitely use slightly less energy to propel a wheelchair on level ground compared to, for normal walking, but it still takes a lot of energy to perform it. Wheelchairs going uphill require increased energy, and going downhill obviously requires a lot less. A below-the-knee amputee requires 10 to 33% more energy to ambulate than compared to normal gait. An above-knee amputation, an AKA, requires 15 to 100% more energy to ambulate compared to normal gait. So like I already said, amputees have a slower cadence, decreased stride length than compared to normal gait. A Sims amputee has the fastest cadence and longest stride length and lowest energy expenditure of any amputee on average. And ambulation with bilateral KAFOs require 300 to 400% more energy compared to normal gait, just because of the extra resistance that is required for that. And just to think about this energy in ambulation as well is depending on, we already said about crutches, but even if they're like using a walker, could be a lot more flexible in accomplishing activities of daily living with crutches compared to a walker. Even using loft strand crutches can be used as well, so that way it's easier to open a doorknob or use other things with those loft strand crutches, possibly, depending on the patient. The other thing too is it's important to communicate with them about footwear, especially for those that have like vascular issues. So that way they can protect their feet from unnecessary injury. Some other things as well, yeah. So just pretty much to prevent trauma with their feet in general is to have appropriate shoes. So causes of amputation, 7% is from trauma, maybe a motor vehicle accident or even gunshots. Peripheral vascular disease or PVD is 90%. And that's usually, especially with smoking and diabetes, is the most common. And tumors make up 2.5% with that as well. Infections are 2%, usually accompanied from PVD. And it's rare to just only see it with just infections alone, but it could also be because of polio or poliomyelitis. And congenital or acquired extremity deformities, believe it or not, is says to be 0.5%, which I think is pretty low than I would have thought it would have been. Now, there's different amputation techniques, and this is like postoperatively. Do they keep the incision open at the time or is it closed? So, the reason why afterwards, if they left the incision open, it indicates maybe there's maybe not enough skin to cover over the stump, or that there's possibly an infection present and they're trying to treat the wound from inside out. There's different closure techniques, and they could also be because of wound contractures or skin grafts or skin traction, secondary exposure. So there's several things that could be in relation to those. Now with closed, so it's closed at the time of amputation. Indications would be minimal risk of infection because it's not exposed, and because of good viable skin to cover the amputation. And depending on the techniques, there's classic myofascial closure, tension myodesis too. Let's see, some other things I wanted to mention. It obviously depends on the surgeon, what they decide, and they're also trying to decide based upon what kind of future prosthetic fitting and function that they will actually have is what they will really determine on what kind of procedure that they will do. Mm, yeah, so I already said that. So talk about for skin flaps. So skin flaps are going to be as broad as possible, and the scar should be pliable, painless, and should not be adhered to the deeper structure. So it should be freely movable with that as well. And so that's the reason why they will put these, they'll do equal lengths of anterior and posterior flaps are often used. So that way the scar is at the distal end of the bone. But just keep in mind, this is really important, that's what I was looking for, is that long posterior flaps are often used in transtibial amputation. And is because of the compromised circulation, um, because the posterior tissues have better blood supply. So therefore they take the posterior flaps and then bring them more anteriorly for the incision because they do have a better blood supply compared to the anterior skin. And the other benefit is that using the calf muscles, they'll reattach it to be better coverage on the distal end of the bone. And the long posterior flaps place the scar a little bit more anteriorly over the distal end of the tibia, and just making for sure that the scar tissue doesn't become adherent to like the anterior bone of the tibia. So it's important to know that's the reason why they do these posterior flaps is because of blood better blood supply, and because of the calf, the gastroc or soleus, they reattach it to provide better cushion over that distal end of the tibia. So some other, they might do some other myofascial or myoplasty, myodesis, or tenodesis. And for most transtibial and transfemoral amputation, they'll use a combination of myoplasty, which is muscle to muscle closure, and myofascial of muscle to fascia closure. And this is just to ensure that the muscles are properly stabilized and do not slide over the end of the bone. Myodesis is muscle is attached to the periosteum of the bone and may also be used to provide a very stable muscle attachment. And rarely you will see a tenodesis where the tendon is attached to the bone, but it could be used for muscle stabilization. You'll see this one, particularly in the foot amputations, because of the extrinsic muscle tendons are cut. So, depending on the technique, with muscle stabilization, they'll take that with under some tension to ensure that the muscles can contract and maintain that muscle bulk and function, especially with using the prosthetic. So here are some post-operative complications that are definitely always possible because if you think about it, especially if they have PVD and maybe they're diabetic and they're smoking, this is all going to put them at increased risk of infections, improper wound healing. bleeding, bone spurs, scar problems, skin graft problems. For anyone, phantom limb sensations, so different than phantom limb pain, by the way, post amputation pain. Now, phantom limb pain is, patients will say that feels like a knife-like, burning, aching, and squeezing, not the same as phantom limb sensation. And the pain can be intermittent or continuous. So use of, TENS, ultrasound, desensitization techniques can be really helpful with that. With residual limb pain, could be because of skin irritation or ulcers, underlying osteomyelitis or osteophytes, limb ischemia, neuromas, um, epidermoid cysts or poorly fitted prosthesis, sensitive scar, and reflex sympathetic dystrophy. So it really just depends on from one patient to the other. But I was going to also say what was talking about in your textbooks about when they do this wound closure at the end of the residual limb, or the RLs, which you're going to see in your textbook. That they will place the incision under great tension, so that might, hold on a second. Yeah, so depending on the bone, a lot of times they will go approximately maybe 1 centimeter above that because of the increased pressure at the end of the long bones into the prosthetic socket, especially for a transtibial amputation. When they are shaving the bones, they make it smooth and rounded, so that way it's not going to disturb the healing or disrupt the periosteum of the bone. And because they could also develop osteophytes with that too. So there's several different procedures that your textbook talks about that you can read over from each one. Another thing is they might also put a drainage tube that is inserted as necessarily after postoperatively. And with the healing of the tissues, it can be without secondary complications of an infection, because it could still be dirty, right? Be considered dirty because of foreign substances, especially if they're like in a motor vehicle accident or some injury of some kind. Therefore, they could be left open and for even 5 to 9 days to prevent invasive infection because of those foreign substances. And to kind of move on. And just know amputations for vascular disease is generally considered an elective procedure, but the surgeon determines the level of amputation by examining the tissue viability through a variety of measures. Probably the most common is using a Doppler systolic blood pressure measurement for the segmental limb blood pressures. And they can also do, a couple different Doppler techniques with that to see how viable the tissue is to determine what level of amputation that they're going to be. Oops. Next, we talk about neuromas, which is a bundle of nerve endings that group together. And, during the surgery, what they will do is they will literally try to pull on these bundle of nerves, because a neuron is well surrounded by soft tissue as to not cause pain and interfere with the prosthetic. So if the major nerves, what they will do, the surgeon will pull them down under some tension and then try to cut them cleanly and sharply to allow them to retract back up into that soft tissue into the residual limb, because some patients might have increased pain from that neuromas if this was not done correctly, especially if the neuromas are like at the incision site or the scar tissue, then they might have generally more pain from that. Here are some different levels of amputation. So transtibial, also known as below the knee amputation or BKA. And this is where 20 to 50% of the tibia is spared. A SIMS is an ankle disarticulation and attachment of a heel pad to the distal end of the tibia. Just know patients with unilateral transtibial amputation, regardless of age, are quite likely to become functional candidates um, for prosthetics. And Many individuals who have bilateral transtibial amputation also can become quite functional ambulators with prosthesis. Older adults with a unilateral transfemoral amputation who have good balance, cognitive ability, and good preambulation functional status are also usually pretty good candidates to receive a prosthetic and for ambulation. Patients with bilateral transfemoral amputations become prosthetic users with microprocessor controlled and externally powered prosthetic components. However, this is a difficult task and requires good balance, strength, endurance, and coordination. There's other like hip disarticulations, transpelvectomies, hemicoropectomies are generally performed either because of tumor, severe trauma, and this just represents a small percentage of the population of these individuals with amputations. The most important factor in determining the prosthetic potential of an individual is his or her level of activity prior to the amputation. So, in general, if they have good hip strength and balance, this is a pretty good predictor that they'll be able to ambulate with their new prosthesis eventually. But just keep in mind, those with those comorbidities, such as like diabetes, this is likely they'll definitely be able to could become good functional prosthetic users, especially if they can demonstrate good balance, hip strength, and coordination. All right. Here's some others. There's knee disarticulation, amputation through the knee joint. Femur and patella are spared. Transfemorals above the knee amputation, or AKA, and that's where 35 to 60% of the femur is spared, and it's usually 4 to 5 inches above the knee joint line. A hip disarticulation is amputation through the hip joint, entire femur removed, and the pelvis is intact. A hemipelvectomy is resection of the lower half of the pelvis. Hemicorporectomy, amputation on both extremities and pelvis below L4 and L5. Transmetatarsal is partial foot amputation through the midsection of the midtarsals. Sorry, metatarsals. There's also partial foot amputations that they can do, like disarticulation of the MTP joint, transmetatarsal, tarsometatarsal, and transtarsal. So here's in your textbook, I want you to make for sure that you know each levels of these amputations and even about the percentages that they could be having amputated. Here are just some pre-prosthetic goals, and to where the desired outcome is for the patient to be able to demonstrate knowledge of proper residual limb care and how well for it to be healed. It should be non-tender and well shaped, and this is going to happen over time. I've dealt with a lot of amputees actually. Amputees really have my heart. I love working with them and providing that motivation with them. And it is a journey, and each patient is completely different. It's not like 1 week later they receive a prosthetic. A lot of healing has to take place. A lot of shrinking of the residual limb has to take place so that that process, because if it's too swollen, it's not going to fit inside the socket very well. So there's a lot of reasons why they wait until they can have that prosthetic limb, and it just really has to do with wound healing and with edema more than anything. So patient education, I mean, telling them about that it's normal of what they're going through, but also how to properly perform wound care, that they're continually checking the residual limb. Don't say stump anymore. People don't usually say stump. Maybe the person with the amputee might, but really the new correct term is more RL, or residual limb. But also if they are needing ACE wrap bandages, which you should learn that in 200 class, or go over that and how to wrap correctly for a residual limb just to help with that edema. And so that way shaping will take more form of that residual limb. And then they could also use some different techniques, like different socks and stockings, to help decrease that swelling. Some other things is obviously we're going to make for sure that they're not going to develop any kind of contractures. So a lot of times telling them to lie prone as periodically as they can so they don't develop a hip flexion contracture, as well as it's good to put if they're transtibial amputation, to put a towel roll above the knee prone so that way that leg can just lay flat out into knee extension. You can also try to do like quad sets with them if they're a transtibial amputation, even putting a weight, like a ankle weight above the kneecap, above the patella to help with those quad sets to improve knee extension if they're having that issue. The other thing they definitely need is to have, good hip extension with these prosthetics as well as good knee extension. So we definitely don't want them to develop any kind of hip contractures, which can be really easy for them to do, especially if they are ambulating throughout the day in a wheelchair. They're constantly in that seated flex position of the hip flexors and the knee flexors. So even on the wheelchairs, they'll have these extensions that will sway over for the residual limb, and that way you can improve with knee extension too. So there's several different things that can be added with that. But just keeping in mind, some other education is that, postoperatively, the biggest concern is infection because they don't want to have to lose any more of what they already have, right? You don't want them to have to go back in and have something else more amputated. Educating them about, smoking is a major concern for wound healing, but smokers have a 2.5% higher rate of infection and re-amputation compared to non-smokers. Other effects of wound healing would be based upon the severity of the vascular problem. If they're diabetic, if they have renal disease, if they have any other kind of physiological problems such as heart disease, cardiac disease. So you not only teaching them about wound care, or maybe smoking cessation, all these things, but also working on proper bed mobility with them, avoiding pressure on the newly amputated limb, facilitating mobilization as quickly as possible and when they're medically approved to do so. But there's quite a bit of exercises you can actually do with them supine, sideline, prone, seated to improve the strength and range of motion of what they need before even getting a prosthetic. You can even do balance training and parallel bars on the non-operative limb, because that limb is going to have to be pretty strong too to be maintaining a balance once they get that other prosthetic. Let's see. Oh, some other things that's important with bed mobility to protect the residual limb is that making for sure, even coming from sitting, that they're not causing more friction when they're getting in and out of the bed with that residual limb, especially where the incision site could be, because with that constant rubbing, it can break open that new scar that's trying to heal. So make for sure you just tell them to lift up the limb when they're moving it, instead of dragging it along the way. The patient should, like kind of what I already said with exercises, but just encourage them to move the limb gently within a pain-free range of motion, especially if it's a transtibial and at the hip for both levels. Gentle hip extension can be performed several times a day, like actively, if they can tolerate, again, resistance. Because any kind of resistive exercises for at the beginning, resistive exercises are contraindicated at the residual limb at this time. So you really got to communicate with your PT as well as the physician of when, um, it is good to add resistive exercises, because if you think about it, that prosthetic is going to weigh how much? And, whenever you're allowed to do resistive training of even, if it's transtibial and knee extension, resisted, then like either with a TheraBand, I would put like some kind of washcloth in place if you're doing a TheraBand, or sometimes that might be really hard as if you're doing with an ankle weight, and if you try to attach it at that distal end, depending how much of the tibia is left, it could easily fall off. So you gotta be very careful that it's gonna stay on properly. Sometimes I just hold it on there while they're doing longer quads to have that more resistance, because that prosthetic could be like what, 5 to 10 pounds. I mean, I know they make them lighter and lighter and more easily not shown, but still, it's more than what they're used to. Some other considerations, let's see if there's anything I haven't said already, but some other goals is, being aware of their cognitive abilities, their physical abilities, their functional status, especially their PLOF, prior level of function, with ADLs, as well as how well is their vision, because that could play a big role in the balance issues. How is their pain? What kind of assistance do they have at home? And do they have a supportive family? Because this is definitely something that is pretty, detrimental for them. And some people handle it pretty well, but for the most part, could you imagine not having a limb anymore? I know that several patients are very discouraged. They're less motivated, especially if they don't have a good support system. They're often depressed. So trying to get them out of that and motivated and in the right direction and encouraging them is the best thing. All right, moving on. So these are just some different ADLs I kind of already mentioned that could be part of that, that you can implement into their program, like bed mobility, ambulation, because you can still do ambulation, just kind of be like non-weight bearing almost without the prosthetic, with either crutches or walker, whatever that you think would be best for them based upon their age and balance. Transfers, wheelchair management, equipment procedures and training, how to use their prosthetic and how to take care of it correctly are all big things on that too. So for the, like I said, the client is usually, or patient is usually emotional. Um, oh, I'm sorry. This is what we want them to go to be, goals for that. Pre-prosthetic psychosocial factors. So we want them to be emotionally well prepared to be in successful training with a prosthesis, to be able to manage it in their life as an amputee with or without the prosthesis. So we'll start to work on when they're a candidate for that of, at the beginning stages, making them eventually more independent with all their ADLs without their prosthetic and even eventually with, but, realistic expectations with their prosthesis, like they might not be able to be a sprinter again if that's what they were before. There might be some things that they have as goals that could be considered unrealistic. Also, understanding how the fit and fabrication of the prosthesis should work too. Um, let's see here. But just to go back to their feelings, I think it's really good not only to encourage our patients, but to also encourage them to express their feelings about their limb loss and address any kind of concerns with patient education and even referral for counseling. And I think this is when it's great for social integration of, having contacts and interactions with others that have amputations, to be as their social network. And because then that way they know exactly what they're going through and they have like built a community, really helps with them mentally and cognitively. Cognition, cognitive impairment from vascular disease can affect memory, concentration, problem solving, and reasoning. So it's always good that you remember that too. All right. But emotionally, these individuals might have unrealistic expectations, thinking that they're going to go back to work of lifting 200 pounds again, so, they worry about providing for their family, providing for themselves, what their future is going to look like. What kind of job are they going to have? Are they going to be able to function in the community? So there's a lot of things that, takes into play of how they're going to heal and be functionally. Here's all these other pre-prosthetic phase general goals that you can look over, range of motion strengthening, exercises, especially for the unamputated lower extremity is always really good to implement, even upper extremity because resistance because of using like assisted devices. So it might have to really make up for the slack of that residual limb. So there's several different things. Now, I'm not going to get crazy into wound healing or stump wrapping because you're going to be doing elastic wrapping or talking more about that in 200. So I'm really going to skip over all this information, but I just went ahead and put it in here for you. I just know about like what a figure 8 means. You just don't want to put it in a circular pattern because it'd be like a tourniquet and decrease the blood supply. So like I said, I'm going to move on and I'm going to get to, oh, there it is. These pre-prosthetic treatment, they're called shrinkers. And this is to help control edema, promote wound healing, and shape the residual limb to eventually to fit that prosthetic properly. It needs to be rather tight and stay on tight. So you kind of do like from the inside out, like let's say that this is the residual limb at the distal. You put that stocking inside out, and then that way you can start from the bottom and wrap it up to the top. And you just want to make for sure there's no, because they usually have lines at the bottom, and you don't want it to be irritating of the skin at the distal end. You want to make for sure it's on all the way and doesn't have any gaps at the bottom of it. Let's see here. What else do I want to say? From that, kind of skipped forward enough even in my notes. Gotta catch up a little bit. Oh yeah, another one, besides just this elastic material you see here, it's pretty popular to see silicone liners that are rolled on more easily. Of course, there's advantages and disadvantages. Sometimes you might even see them wear socks and then they silicone liners because of like oftentimes they don't sweat very well, right? So sometimes some people wear socks on too. Different kind of prosthetic socks, by the way. But shrinkers are used best used after healing has taken place and initial postoperative edema has been reduced. So usually they might get the ACE wrap bandage done first, and then have these more sock-like garments that are made from elastic or silicone liners. Mm. So criteria for to use these shrinkers is based upon, no skin abrasions and, like I said, promote shrinkage of the residual limb. All right, so phases of care. So there's post-surgical phases for all these different functional balance, residual limb care, patient education, discharge planning, into pre-prosthetic phase as well. And the earlier on they get rehabilitation, this will produce a greater potential for success. If there's a long delay, and then they might develop more joint contractures and be even more depressed psychologically. But just know the post-surgical phase is the time between surgery and the discharge from the acute care hospital where the surgery occurred. The pre-prosthetic phase runs from acute care hospital discharge to prosthetic fitting, and the decision is of the patient to see if they're going to be a candidate for prosthetic. So you can read over all the other things involved in that, and even with the discharge planning of what depends on their home environment, if they're going to have anybody that's going to help them at home, are they going to need a walker? Are they going to need other things to be discharged home with? Here's some post-surgical phase general goals of, still promoting healing, optimizing the range of motion, and optimizing strength of both lower and upper limbs without impairing the residual limb healing. So at this point, you should start to be able to implement more resistance type training depending on how the scar should be, how it's healed. Nothing's altering the healing. So all of that too. But just keep in mind, I forgot to say that those in the hospital, they usually are only in there for a limited time. And the hospital lengths are typically shorter. So with us treating them, it's, a lot for us to try to get them prepared and ready to go home and safely go home. They might even go to a rehab floor, sorry, rehab center, temporarily. Here's some other post-surgical phase interventions as well. We just want to definitely make for sure they're not having any contractures and that we're doing everything we can for the healing. So that way, when they do receive their prosthetic, they'll be ready to go pretty much. It says we should encourage them to lie prone 30 minutes a day. I would say multiple times a day if all possible, and to avoid a pillow under that residual limb while they're laying in supine, just kind of like how you would with a total knee replacement. You don't want them to develop that knee flexion contracture if it's to transtibial. You also want to avoid them lying sideline, especially if they are a transfemoral amputation. A lot of times they will automatically get into this contracture of hip abduction just because of trying to maintain balance. And, just making sure that they're avoiding excessive pressure of the residual limb, especially if a knee immobilizer is used, especially if it's a knee Yeah, it says it's usually not safe for them to use a knee immobilizer with ambulation, which I really haven't done that before. That's probably why. They could also have rigid dressings, which I really haven't had any patients have that either. We're just really working on range of motion and maintaining that and improving strength. So when it talks about center of mass and how that's oft altered, usually if they try to stand on one leg, just like anybody else, then they try to make up for that and recompensate either by leaning on the good limb to maintain their new center of gravity. So it's really important, like we said before, about looking about their vision, what's their vestibular function, so that way we can accommodate this quickly as possible with their balance, if they have any balance issues, and that way they're more safe with bed mobility and transfers and gait. Now, the phantom sensation, this is non-painful sensation in the part of the limb that has been amputated or removed, and this might be a default to the learned motor patterns that include the now absent limb. And, they might periodically stand and transfer, leading with the unamputated limb to protect the residual limb. Okay, never mind. Okay. Anyways, yeah, so doing balance training with these individuals is really good. I have a whole handout about phantom limb pain that I do want you to read over because there's a lot more detail with that. Here's just some other, kind of talked about all of these. So some values of exercise is that it does improve circulation, increases muscle power, corrects existing contractures, increase range of motion, decreases their sensitivity. So there's like desensitization techniques that are really helpful to do, like especially if they're having issues in sensitivity, pain, with that like sharp leg pain, using these like even with cotton ball or washcloth. There's different desensitization techniques to be used, so that way it doesn't hurt when they do get their prosthetic limb. Anything to help with coordination, like reaching outside their base of support with balancing training. There's different techniques you can use with that. Here's the major problems based upon contractures. If it's above the knee amputation, usually hip flexion abduction contractures. Below the knee would be hip flexion abduction and knee flexion contractures. And with that, like above the knee amputation, a lot of times they'll have weakness of adductors and internal rotators because they're more stuck in abduction and external rotation. Below the knee, they usually have more weakness associated with the quadriceps. So it can also have tight hamstrings too. So with proper positioning, correct bandaging, and exercises, hopefully we will be able to prevent any of these contractures from happening. So here's all the different exercises that you can go through that you can with an amputee to prevent these contractures. And they're different from above the knee and below the knee, so you can read over those. And these are just some additional lab components that you can look over to see what would be beneficial. I definitely want you to look over, there's a scenario out of your textbook, and I'm trying to just figure out which one that was. There's tons of video resources on there. That handout about phantom limb pain, I think would be good to look over. Sorry, I was trying to figure out what that other name of that. Oh yeah, in your textbook, there is a patient with a transtibial below the knee amputation. There's actual videos and printed case studies on that. So I definitely want you to see that video case study and the examinations with that. And from your textbook, you'll probably have to go online under the resources, and I believe it's O'Sullivan. Don't quote me on it. I want to say that it definitely is O'Sullivan. And I think that concludes everything that I wanted to talk about. So, yep. So make sure you look at all of those important tables in your textbook, anything to do with the different levels of amputations, as well as contractures, exercises for contractures, who's going to be at more risk of developing these types of conditions, even for the alterations of healing, anything of, when should you do resistive training with these individuals, as well as cognitive, and what's the difference between phantom sensation and phantom limb pain. Try to think, and any other important tables that I was mentioned in your textbook for you to know the differences for each one. And that concludes our lecture for today. Thank you.